Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues and PGs, we are discussing pregnancy-specific liver diseases. In the first vlog, we discussed the general changes, the normal physiological changes in the liver functions, the liver parameters in pregnancy. Then in the last vlog, we discussed the first case history. That was the hyperemesis gravidarum. And we learned what's the diagnostic criteria, how these patients present, what are the effect of hyperemesis gravidarum on liver functions, how we treat these conditions, and what's its impact on the mother and on the fetus. And what are the risk factors for hyperemesis gravidarum. And we learned that the most common presentation is in the first trimester. Today we shall discuss a second case history in the pregnancy-related liver diseases. And we shall learn that how this condition presents, what is the diagnostic criteria, how we treat, and what's the impact of today's disease on the mother and fetus, what are the risk factors for this disease to happen, and what's the prognosis. So let's start discussion on the second case history. Our case history number 2 is about a pregnant lady with a intractable itching on the palms, on the soles, on the body. Let's start the case history. It's a 37 years old, multipara, 20 weeks pregnant lady presented with pruritus, which is most severe at night and occurs mostly in the palms and soles without a rash. Palms and soles without a rash. So, a 37 years old, multipara, 20 weeks pregnant lady with pruritus, most severe at night, and occurs mostly in the palms and soles without a rash. On examination, she is mildly ecteric with scratch marks on the body. The liver functions: bilirubin 2.3 milligram, ALT 167 units, raised, AST 105, alkaline phosphatase 200, and serum GGT 40 international units. So at 20 weeks, multipara with pruritus and deranged liver function tests. The serum bile acids were 23 µmol per liter. And ultrasound showed polylithiasis. So the question is, what is the most probable diagnosis? And second, how will you treat her? So, a lady in 20 weeks pregnancy, multipara, pruritus, ultrasound showing gallstones, LFT is deranged, bile acids 23. So you write down the diagnosis and let's see whether our diagnosis is correct or wrong. The diagnosis is intrahepatic cholestasis of pregnancy. Please remember the color coding. For hyperemesis gravidarum, we use the dark blue colored, rather dark black. And the second color coding is that of intrahepatic cholestasis of pregnancy, which may happen, which may appear in the second trimester till third trimester. So second and third trimester is the time duration for intrahepatic cholestasis of pregnancy. We learned that the hyperemesis gravidarum mostly present in the first trimester, and the intrahepatic cholestasis of pregnancy may present in the second or in the third trimester, or may start from the second trimester and go till the third trimester. What is the diagnostic criteria? We learned the diagnostic criteria for hyperemesis gravidarum, the three criteria, that intractable vomiting, and then the leading to the dehydration and electrolyte imbalance and loss of body weight of 5% of the pregnant weight. What's the diagnostic criteria for intrahepatic cholestasis? This is important. So the first criteria is, or the first requirement is pruritus without a rash in the absence of other liver diseases in a pregnant lady beyond 25 weeks gestation. So it should be a pregnant lady beyond 25 weeks gestation, and there should be pruritus without a rash. This is important. Pruritus without a rash. Scratch marks is something else, but without a rash, pruritus, and there should be no other liver diseases. And this pruritus should be accompanied by elevated serum bile acids, more than 10. Our patient had 23, so it was more than 10. And the onset of pruritus typically precedes biochemical abnormalities. Patient comes to you with pruritus, you check the liver functions, they are normal, and when you follow up that patient's down the time, in 1 to 2 weeks, the liver function starts rising, and of course the bile acid levels, they are more than 10. Serum bile level of more than 40 means severe intrahepatic cholestasis of pregnancy, and it is associated with fetal distress. So the bile acids checking is very, very important. Determine the bile acid levels. One is that it is important for the diagnosis of intrahepatic cholestasis. And second, its level is directly related with the prognosis. More than 40 means severe intrahepatic cholestasis of pregnancy, which is associated with fetal distress. Jaundice may occur in 17 to 75% of the cases of intrahepatic cholestasis of pregnancy and typically develops 1 to 4 weeks after the onset of pruritus. In Our Lady, the bilirubin was high. So first, as I said before, pruritus comes followed by the jaundice or the deranged liver functions. The total bilirubin levels are also increased, but usually the values are less than 5. In our patient, it was 2.3. So this is another point. The elevation of aminotransferases associated with ICP varies from a mild increase to a 10 to 25-fold increased. In our patient, they were mildly increased. So the bilirubin is mostly less than 5, but the ALT, AST, they may be mildly raised or maybe even to 10, 25-fold. And these liver enzymes dysfunctions or levels, they come after the onset of the pruritus. Alkaline phosphatase is elevated in ICP up to 4-fold. But this is not helpful for diagnosis. We know that because alkaline phosphatase is elevated in pregnancy due to production by the placenta. So the level requirement, the criteria required is, of course, the bile acid levels more than 10. We continue our discussion. Mild elevation of gamma glutamyl transferase, that is GGT, is seen with ICP, but occurs in fewer than 30% of cases. So it may be normal. If GGT is elevated in cases of ICP, the patient is more likely to have a genetic component of the liver disease. It tells that probably there is some genetic component of the liver disease as well. The cholic acid level is significantly increased, and the chenodeoxycholic acid level is mildly increased. Both the cholic acid and chenodeoxycholic acid, someone call it chenodeoxycholic acid, both are raised, but cholic acid level is markedly raised as compared to the chenodeoxycholic acid, and this leads to the elevation in the chenodeoxycholic acid level ratio. Both are increased, but the cholic acid is disproportionately highly increased as compared to the chenodeoxycholic acid. Once a diagnosis of ICP has been made, total bile acid levels can be followed weekly to guide therapy and timing of delivery. This is very important. You make the diagnosis of ICP, then you check the bile acid levels weekly or fortnightly, depending upon how the level is, to guide the therapy, what you are treating, and to time the delivery. If bile acids are more than 100, delivery is important at 36 weeks. If bile acids are less than 100, delivery between 36 and 39 weeks. We knew that more than 40 means severe ICP. If it is between 40 or it is less than 100, it is less, of course, then delivery may be plain between 36 and 39 weeks. But if it is more than 100, then delivery at 36 weeks must be plain. In addition, coagulation studies and transaminase levels should be monitored to measure progression of the disease. So this is, once you make the diagnosis of ICP, how you proceed, how you monitor the disease progression. Serum bile acids and ALT levels decrease rapidly after delivery. Once the delivery is done, they will decrease rapidly and normalize within a few weeks. LFTs and serum bile acid concentration should be checked at 6 weeks after delivery. So once ICP was diagnosed, delivery has done. So after 6 weeks of delivery, please check the bile acid levels and LFTs. If there are persistent symptoms of or deranged LFTs post-delivery, other liver diseases such as primary biliary cholangitis and primary sclerosing cholangitis should be excluded. So they should be normalized at 6 weeks. But if they are raised, persistently raised, their symptoms or the LFTs are deranged, then you exclude primary biliary cholangitis or primary sclerosing cholangitis in such patients. ICP occurs, that means intrahepatic cholestasis occurs in 0.3 to 5.6% of pregnancy, usually occurs in second and third trimester of pregnancy and resolves with delivery. So it may start in the second or third trimester and it resolves with delivery. So the monitoring is very important. It goes till the delivery. Sudden intrauterine fetal death is a rare event, 1 to 2%, but is unpredictable and remain the most feared complications of ICP. That's the reason the diagnosis of ICP is very important and the monitoring is very important. Risk factors for ICP. Who are at the risk of developing ICP? Multiparity, as in our patients. Advanced maternal age, our lady was of 37 years old. Metabolic syndrome, if the patient is obese or hyperlipidemia or fatty liver or diabetes or hypertension or the cholesterol and TG levels are high, then chronic hepatitis C infection, if the patient had chronic hepatitis C. Personal or family history of ICP. This is again very important. And previous cholestasis while on oral contraceptives. When you dig out the history, then the patient developed cholestasis while the patient was using oral contraceptives. So these are the risk factors that such patient may develop intrahepatic cholestasis of pregnancy. Multiparity, advanced maternal age, metabolic syndrome, chronic hepatitis C, personal or family history of ICP, and previous cholestasis while on oral contraceptives. Pathophysiology involves reduced bile flow, leading to bile acids deposition in the skin and placenta. A combination of hormonal, genetic, and environmental factors are thought to contribute to this reduction in bile flow. There's mutation in the ABCB4, and what the ABCB4 means, adenosine triphosphate binding cassette subfamily B member 4. So this gene, the mutation in this gene has been found in patients with intrahepatic cholestasis of pregnancy. The ABCB4 gene encodes the hepatic phospholipid transporter MDR3, multi-drug resistance 3, the bile salt export pump, and ATP8B1. So because of this, when there's mutation, the bile flow is reduced, and there's deposition of bile salt in the skin and placenta. And because of the bile salt deposition in placenta, the worst outcomes in the pregnancy happens. The first line therapy is, of course, the ursodeoxycholic acid, which is recommended by the American College of Gastroenterology, American College of Obstetrician and Gynecology, American Association of Study of Liver Disease, and EASL, European Association of Study of Liver. The dose recommended by the ACG and AACLD is 10 to 15 milligram per kg per day, while the EASL is going a bit higher from 10 to 20, maybe 26 milligram per kg per day. We know that ursodeoxycholic acid is a hydrophilic bile acid. It reduces pruritus as well as ALT and both maternal and fetal bile acid levels. There are no adverse effects for the mother or fetus, and it may reduce risk of fetal complications. So the first line therapy for intrahepatic cholestasis pregnancy is ursodeoxycholic acid, and this is the dosage given. The second line therapy is, of course, as recommended by the AACLD, RCOG, Royal College of Obstetrician and Gynecology, American College, and EASL, is the S-adenosyl methionine. Then rifampicin, which is recommended by the AACLD, ACOG, and EASL. Cholestyramine, recommended by the ACLD and ACOG. Dexamethasone, just like steroids were given in hyperemesis gravidarum, similarly here by the RCOG. So these are the second line drugs. Antihistamines can be used for sedation at night, but do not improve pruritus. This is important. And what has been recommended by the ACOG, American College of Obstetrician and Gynecology, these are the diphenhydramine and hydroxyzine, and by the RCOG, chlorpheniramine. Topical emollients are also safe for use. Vitamin K supplementation at 5 to 10 milligram daily is recommended if the PT is prolonged, with more frequent monitoring of PT in women taking cholestyramine. If the patient is taking cholestyramine, then of course you need a more frequent monitoring. Maternal prognosis is usually good. Cholestasis frequently recurs in subsequent deliveries, 60 to 70%. So in subsequent deliveries, it may appear. ICP is not a contraindication for oral contraceptives. So if a patient wishes to use oral contraceptives, she can use, and may be started once the liver tests have normalized after delivery. ICP has a high rate of recurrence of up to 90% of subsequent pregnancies. The cholestasis can happen, but the ICP fulfilling the criteria in more than 90%. It is also associated with an increased risk of cholestasis with the use of the combined OCP, high rates of cholestasis, and a slightly increased risk of developing even hepatobiliary cancer. So this is one of the bad impact outcome in the mother. So I stop here. I hope that in this case history of intrahepatic cholestasis of pregnancy, you learned that it may appear in second or third trimester, and it resolves by the pregnancy, by the delivery. We need to do the proper monitoring, the criteria that the pruritus followed by the liver enzymes elevations, and then the serum bile acid levels more than 10. If it is more than 40, it's a severe disease. And the regular bile acid monitoring is important. If it remains less than 100, you plan the pregnancy between 36 and 39 weeks to the delivery. And when it is more than 100, then the delivery should be done at 36 weeks. We understood what are the risk factors for it, and we learned that how it impacts the mother as well as the fetus. So I stop here. In the next vlog, we shall discuss the third case history. So be with me. Till then, it's Khuda Hafiz.